what is the time, Manoj? Like mine is showing.
I think we 3 minutes past the time. I think we can start. Or there are only 52 people who are joined by now. Do you want to wait for 2 minutes? You're muted. Yeah.
Am I muted?
Yeah. Now you're audible.
2 minutes. We'll wait and we'll start it off.
Professor Satyan, shall I rename you, or do you want to rename yourself? It's written as faculty, so
Sure, I'll rename myself.
yeah.
Dr. Rahul, you there? Hi, Rahul.
Hi, Rahul.
Hi, Rahul. How are you?
I am good. How are you, sir?
Good.
Yeah, Manoj.
7:05. I think we will start.
Already have 100, so we can start off. And so, shall I start? Yeah. Good evening, everyone, and welcome to another session of NOEL, the NNF Online Education Learning Program for the Fellows of National Neurology Forum. And this session is very special for us, and good morning for Dr. Satyan and Dr. Franklin, and thank you very much. I know it's a very early morning for you. Thank you for your efforts to participate in NOEL. As a neonatologist, it has always been challenging for us to decide what to do with PDA. And for those who have been sort of seniors whose hair have turned gray, treating the newborns, they know we have passed through different evidences about what to do with treatment, right from prophylactic management to being conservative to surgical closures, to be aggressive, not to treat. So many evidence have come. And different types of medications, indomethacin, to brufen, to paracetamol, what is to do. And what happens to them in long-term outcomes. So there is always a challenge. And again, how to assess them right from clinically to echocardiography. So it's always very, very interesting to know what is the latest. And when we thought about this topic, we thought there should be someone special to be invited as an expert. And when I called up Dr. Satyan, and I think Dr. Satyan doesn't need introduction in India. And thank you, Dr. Satyan, for accepting our invitation. As you know, Dr. Satyan is professor and chair of pediatrics and pediatrician chief from UC Davis Children's Hospital, California. But all of us know him more from his special way of explaining things. Let it be persistent pulmonary hypertension, newborn resuscitation, or the way he designs the cartoons, his pictures. I think the way textbooks are written, he has revolutionized it. And he's so friendly, he sort of shares his cartoons with everyone. And recently, even the COVID, I can tell you, Dr. Satyan, most of the people, whichever talks I've heard from perinatal, they use your cartoons. And thank you very much. Right from the MISN to everything, people use their cartoon. And it's so self-explanatory the way, things work. Right, immunity. You make it so simple with those, let it be persistent pulmonary hypertension or even the retest MISM. So thank you for that. You not only agreed to come on board, but also offered Dr. Franklin. We have a very special guest, Dr. Franklin. Dr. Franklin is one of the very few people who have got masters in Society of Cardiac Angiography and Intervention Cardiology. He heads pediatric cardiology study services at UC Davis Children's Hospital. And as you know, as I said, what has been, and I think we are still learning, and there are a few case reports from India, cases where people are doing about device closure in premise. We're looking at how to, and when Dr. Satyan told that Dr. Franking had a huge series about device closure of premise, I thought it would be very nice for us to share his experiences. He's a very busy man. He has his cath lab very soon. So what we're going to do is have his lecture in the beginning so that we all are aware about, what is the current practices about PDA, what is the expertise available around the world, and see what can be done. Because when we're looking at our cardiologists, interview cardiologists, availability of the, catheters, there are a lot of which we can sort of address it. I also take the opportunity to thank other expert for the session, Dr. Rahul Yadav. Dr. Rahul Yadav is the Chief Consultant Neonatologist, the Director at Rainbow Shields Hospitals, Chennai. Thank you, Rahul, who also, supervises the training program there. And let me take this opportunity to thank Dr. Ravi Shankar. As you all know, Ravi Shankar he's a senior neonatologist. He's the CEO and director at Somnath Children's Hospital. And his main interest has been functional echocardiography. He has given a number of talks in conferences, conducted a lot of workshops, and he has interest in PDA. That's why I thought he would be the right person to sort of moderate the session. And it is his unit who is going to present today's cases. So the way we start today's session would be, let us start with Dr. Frank's experience about a catheter closure, a device closure of PDA in premise. Off to you, Dr. Franking.
Okay, well, thank you for the introductions. Let me see if I can share my slides first. Can you guys see this?
Yes,
we can see.
Okay. Perfect. Okay, so I know I have 15 minutes. I'm going to go really fast here. This is primarily an introduction to this particular procedure, which is going to be the transcatheter occlusion of the PDA in the very low birth weight infant. So the discussion points for the lecture is going to be first about the different devices that are available that can be used in this scenario. I'm going to go over a little bit of the history of the procedure, starting with older patients and getting smaller and smaller and smaller. I'm particularly going to focus on two devices that are used currently, the MVP or the microvascular plug and the Piccolo device, and some of the technical considerations, and then I'll summarize. So historically, the PDA closure was first reported back in 1967, so a long time ago, by Portsman. At that time, the system was delivered through a 24 French sheath. Of course, this is a huge system, so it was mostly done in adult patients at that time. But nevertheless, that was the first device that was created for PDA occlusion. Now, in 1975, Dr. King came out and came up with his device that looks like this. Now, these are pretty much dinosaurs at this point. Nobody will use this. This, I think, was pared down to a 18 French sheath. So a big jump in getting smaller from 24 French to 18 French. Okay, I'm trying to, and then of course, in 1981, Rashkin came up with the Rashkin device, and that became the big one. Now, I was in med school at this point, and I still remember hearing about this at that time. Of course, 1989, the geointegral coils that were used by the radiologists to occlude collaterals came along, and Dr. John Moore came up with the idea of using this in the PDAs. That also took off and really expanded this whole field of PDA closures, again, mostly in older patients and children. When the Amplatzer ductal occluder came out in 2001, that was a game changer because this was a very well controlled device that can be put in, repositioned, retrieved if needed. And this was able to go down to the infant size. And then the geointegral Griff-Cassack came out in the 1990s. This was a little bit of a cumbersome device that eventually went out of market because it just could not compete with the Amplatzer ductal device. Now, this is the current status here. The ADO, or the Amplatzer ductal device, first generation, went through a 5 to 6 French sheath. So as you recall, the first version of the PDA device was 24 French. And 30 years later, 20 years later, it's come down to 5 to 6 French sheath. The second generation came along. You can see that the sheath is now smaller, the delivery system smaller, everything's more refined. Now, these can actually go into babies that are less than 6 kilos at this point in time. So this was one of the papers that came out in 2010. We were quite excited to find that that device can actually be used or go down to 6 kilos and less. I'm not going to go through the details, but pretty much this was a successful device in babies as low as 2.3, 2.4 kilos. And that time it was a big jump down below 6 kilograms. Now, when the Amplatzer vascular plug came along, the second generation, a couple of papers came out in 2013, which then basically said these devices can go down to two kilos or so. And I think we're going way down from adults to pediatric size to infant size, and now to about 2 kilos, 2.5 kilos. Now, what about the preterm patients? And we know that the incidence of PDAs are somewhere around 57 out of 100,000 in this group of patients. In the preterm infants, 33% will have them. And when they're less than a kilogram, about 50% of these babies will have PDAs, maybe more. So I just showed you the two devices, the first generation and the second generation of the Amplatzer ductal occluder. Well, along came the microvascular plug. This is made by Medtronic. So you can see now when you put them side by side that this is even a finer system. It goes down to a 4 French, and the delivery system is even more refined. Now, the second one that came along, this came out in 2019, the Piccolo device. You see side by side next to an American dime. You can see that these are very small delivery systems, small devices, and these are pretty much the size of an umbilical catheter at this point. And I'm just showing you an example in the cath lab where you can pull this into a delivery system and you can push it out pretty easily. And they come in 3, 5, and 7 millimeter diameter devices, and even a 9 millimeter device that can go through a 4 French catheter. But the smaller ones can actually go through a 3 French micro catheter. So here's a patient that has about a kilo in size. You can see how small the baby is. We keep the temperature by using plastic wraps just to maintain some loss of body temperature. We can go down to the 800 gram. We did this 800 gram twins, one after the other. And I'm just going to give a presentation of one. This is a 7-week-old, 23-week premature infant who had a large PDA, pulmonary hypertension, chronic lung disease, all the things that you guys are familiar with. I had a couple of trials of medical therapy that failed. So you can see this patient was actually a 625 gram, very small baby. You can see the vessels on the skin. So we bring him in. You can imagine these vessels are quite small. So we actually use ultrasounds to gain access into the groin, into the femoral vein. Now we actually have our echocardiography colleagues going under the sheet, echoing to give us the images so that we can avoid getting an arterial line so that we can look at the aortic flow when the device goes in, because the babies are small. We want to make sure the device is positioned without obstructing the aorta. In the old days, we put a catheter in and take a picture, but because we don't want to damage the femoral arteries, we will use ultrasound. So here's just an example of the ultrasound. You can see that the red color there is the PDA flow back into the pulmonary arteries. Here's the wire going up through across the tricuspid valve in the right ventricle, and eventually will make its way out to the MPA across the outflow tract. These are quite small hearts, but these wires are very soft, and eventually we can just find our way through. Usually it just pops through the PDA and down to the descending aorta. And then with that, we can run a catheter over that into the PDA to the descending aorta. We can take a picture. You can see that in this small baby, the PDA is about the size of the aorta. You can imagine there's a lot of left to right shunting through this large PDA. So here's just a still frame. This is measuring about 2.7 millimeters in diameter, quite long, 12 millimeters in length. You can see it's almost the size of the aorta. So here's the yellow line is the ductus with the red arrows defining the aortic entrance and the pulmonary entrance. And now we use the ET tube or sometimes the temperature probe as a reference. You can see that most of the PDAs will be positioned around this area. So here's the, again, the picture of the PDA. And then we're going to use this particular 5 millimeter device. And this is a nice illustration from Dr. Satyan showing how the catheter course from the IVC through the right atrium, right ventricle, across the pulmonary valve, into the MPA, across the PDA, and down the descending aorta. And so here's the device going in, and we're delivering this under fluoroscopy. And then, of course, what happens is that sometimes the device is not put in position, but I can tell you that we can actually withdraw this and reposition it back. And the red arrows was just to show you where we need to land the device based on the images that we have. So the red arrows represent where the PDA is located. Now, in this point in time, you notice that the device is delivered a little too far, but I can actually pull it back in. So see, just again, you can see how as I'm withdrawing the device, advancing the sheath, I can eventually gently bring the device back into the sheath, and we can redeliver the sheath back into the PDA. And at this point in time, we can do it a second time and reposition this and make sure that we're within those 2 red arrows. Of course, the red arrows are not there during the case, but we have our reference images to help us know where the device is. So at this point, the device is delivered. We take a little picture. You can see there's good flow in both the right and left pulmonary arteries, but the device is hard to see. What you see is the 2 black dots representing the 2 ends of the device. And then with this, we put our echo. We can see that there's no left pulmonary artery obstruction based on the Doppler flow. And then we basically will release. At that point, the release, the device is in position. We echo it again. You see that the aorta flow is blue. There's no turbulence. And then that's where the position is. Here's the pressures of the PAs before. There's a pressure that have dropped after we release the device blocking the flow. And this is what it looks like afterwards. I cut out a lot of the other imaging to show you by echo that we have to make sure that the device is in good position with no obstructing the flow before we release it. But I only have 15 minutes here. So here's the picture after we release. Here's the LPA, again, very homogeneous flow that does not show any turbulence. And here's the aortic flow. And somewhere right in this position here is the device where my arrow is located. Now, this is just a picture of the X-ray before and after. Clearly, you can see that the pulmonary vascular markings are improved, and you see the heart size has gotten smaller. The edges are improved of the heart at this point. And here's a baby and a baby after discharge and back at in the clinic. Here's another patient where we're using the Piccolo device. This is actually just a 570 grammer X25 weaker severe lung disease on an oscillator. You can see how the transportation can be quite precarious. It takes about 5 to 6 people to transport the baby and slowly transport the baby from the oscillator to the cath lab table. Here's the baby, and very carefully changing out the high frequency ventilator from the transport system to the oscillator in the cath lab. And you can see how just a close up the belly, you can see the movement of the abdomen from the oscillator therapy there. Right there. See lots of movement. So again, this is a baby that's not exactly the most stable, but just to show that we can actually do this even when the baby's on an oscillator. So here you can see that the femoral vein and the needle going through. I just want to show you that you can actually see the vessels, and as you poke in the needle, you can actually identify where the location of the vein is and get your needle into the vessel to get your line through the small vessel. This is the Piccolo device. You can see how this is going through a 4 French system, and it can go in through a tiny little catheter. It's made out of nitinol, which is nickel titanium. It's a metal that can bend and reform its shape after you've opened it up without being constrained. So here's the catheter. Again, you can see that this is a very large PDA. The minimum diameter was actually 3.2 millimeters. Again, the size of the aorta. So a huge shunt left to right. You can imagine the pulmonary pressures and a high pulmonary flow. Here's the device going in. This is the Piccolo 5.2 device. So 5 means 5 millimeters in diameter. You can see we put the device in. Now, the reason I show this to you, here's the still frames of the PDA. You notice that here's the temperature probe right here. So we know that the device have to sit somewhere in this region here, right by the temperature probe. And here's the device very in the proximity of where that temperature probe is and where the arrow for the ductus. And so this is what it looks like. Again, you'll see that the device is there, and then we are happy with this. We can release it. And at the release, you notice the device is very stable. It doesn't shift at all, but it's, again, very in the vicinity of the temperature probe. And here's the picture afterwards. You see there's good flow to the right and left pulmonary arteries, and the device is in good position. On the ultrasound, we also look at the aortic flow to make sure there's no obstruction. If there was, we could reposition it before we release. So the images before release is very important here. So here's the aortic flow. Again, you see how it's very homogeneous. There's no turbulence there. And here's the pulmonary artery flow with a good flow to both pulmonary arteries as well. So there's that same baby, and we're now transporting it back to the transport system. We use the TXP transport system that has a high frequency ventilator that is part of the system that allows us to transport from the ICU to the cath lab and back. This is the X-ray beforehand. You can see how congested the lung is, and the heart shadow can't be seen. This is right afterwards. You can see how the lung still does not look great, but a lot better than before. And you can at least see the edges of the heart, and you can see the device in this region here. Now, that's not uncommon. This is very typical of some of the cases. I don't even have to tell you which is the pre, which is the post. You can clearly see that after every case, this X-ray before, X-ray after, the lung markings are improved, the heart size, the edges will actually be seen, the silhouette sign is there, and the heart size oftentimes will get smaller. And this is very common. And these are some of the babies that we've seen, and this is what they look like afterwards. So it's very satisfying to see them in the outpatient clinic. And some of them are actually 3 years old now, running around, and they're all very happy to see them have done well. So let me just summarize that there's a long history of PDA occlusion. There's new technology and experience that has steadily decreased the size and weight of the patient in whom this procedure can be performed safely and effectively. It can be done safely and effectively now in very low birth weight infants down to 600 grams or so, even on those on oscillator ventilators. Echo guidance to eliminate the need of the femoral artery access is important. Homeostasis during transportation in the cath lab is essential, and it requires a multidisciplinary approach. So far, so good. Thank you for your attention. I'm going to unshare my screen.
Thanks, Frank. That was a great overview. We can open up for questions for Dr. Ying.
Yes. Hi, Frank. Thank you. The excellent presentation and excellent experience about PDA closure. Just to open up the discussion, the indication for device closure, is it going to be in your unit? Is it same as what would be the surgical indication which all the units would have? Have you stopped surgically ligating your PDS? And that's what we would like to know.
So I can start a little bit and maybe starting to jump in. First of all, as an interventionist, I truly believe this is one of those procedures that are multidisciplinary oriented. And I do think that neonatologists are the gatekeepers because you guys manage these patients. I'm merely the technician here. So in some ways, I feel that this is better than a more invasive surgical procedure, meaning that we don't have to cut open the chest through the intercostal muscles. And so for the respiratory mechanics are definitely not a problem after the procedure. You can clearly see the improvement, at least on the x-rays. As far as the improvement in the clinical improvements, now again, that may or may not always happen quickly. I know there's a lot of data out there showing that if you left these babies alone, the long-term outcomes are no different. And that may be the case. And I think there's still a lot to be discussed. I actually had a lot more slides about these kinds of issues, but I left it out because of the 15-minute limitation. But as far as the decision, I always thought that, yes, if you think that kid needs to have surgical ligation, this should be thought of as the next option. But in my mind, I think that if you look at surgery ligation, it's probably a much higher threshold to bring a baby to surgical ligation. So I actually think that sometimes the decision to close the ductus after medical therapy may be even longer than it should be. The data so far shows that if you do the babies between 2 and 4 weeks, the outcomes are actually better. And again, there's some larger series out of Labana children showing this. That if you wait long enough, you're going to have the chronic lung disease, which will not go away even you get rid of the PDA. But certainly you get rid of the hemodynamic derangement of the left or right shunt, and certainly it's a lot less invasive. So I do think that this is more of a decision that should be made with the neonatologist. Obviously, the interventionists can get involved and discuss, what can be done, how to do this safely, and so forth. But you guys are the gatekeepers.
Dr. Satyan, I might ask you this question because we have also a great intervention cardiologist. And at this stage, when it was great to see Dr. Frank's experience about ligating a 600 grammer and 900 grammer, though in India, the availability of this small sort of catheters and device is a big challenge. So how do you take this call about which one surgical ligation, which one transcatheter closure, or you're not doing surgical ligation at this stage?
Dr. Dinesh, the last baby that underwent surgical ligation in our NICU was in January 2018. No, actually, I take that back, April 2018. So we have not done any surgical ligations ever since this device was available and Dr. Ng came to our institution. The issue with surgical ligation, as Frank was mentioning, is that the morbidity is much, much higher. And as you know, it's a fairly large incision that you need to place. Thoracoscopic closure is not very easily accomplished. And the risk of post-ligation syndrome is extremely high. So this, almost 2/3 of these babies after they undergo surgical ligation land up with some kind of exacerbation in respiratory morbidity. And the other issue we were facing is that a good number of babies, I want to say anywhere from 1/3 to half of them do experience vocal cord dysfunction. This is something that typically neonatologists, we don't think about, but there have been case series where they have prospectively gone and looked. In other words, you do a surgical ligation, you go back and do a ENT evaluation of the vocal cords and see if there is vocal cord paralysis or weakness. And the incidence of that is considered to be pretty high. Anywhere from almost half of these babies have some degree of vocal cord weakness, preventing easy extubation. The main advantage of surgical ligation is that in most units, it can be done right at the bedside. So you don't have to transfer the baby. And right now, Dr. Ng is working on protocols. Right now, the main concern I have before I call Dr. Ng, in fact, I have a 22-weeker right now in the unit who has a large PDA with a huge left atrium, who is almost more than a month old, stuck on a ventilator. And I need to call him after we're done with this call to come and do a consult to talk to those parents to see if this is the right approach. So the main concern that we have right now is transporting the baby from the NICU to the Cath lab and back, especially when the baby is extremely sick. And I'm happy to state that Dr. Ng recently took one of my patients and did a closure using ultrasound or echocardiography. And if that becomes a bedside procedure, my threshold for requesting a cath-based closure would be much, much lower than it is right now. So our protocol right now is to consider a respiratory score. In other words, the baby should have respiratory morbidity. If the baby is in very low flow nasal cannula and are not requiring a lot of respiratory support, then there is no indication for PDA closure. So there has to be a combination of a hemodynamically significant PDA with respiratory morbidity and typically failed one course of medical treatment. So either one course of acetaminophen, indomethacin, or ibuprofen. After one failure, we request for a consult and we discuss with parents the pros and cons and get the babies done. The beauty of this procedure is that there is no post-ligation syndrome for the most part, which defies physiology as to why it doesn't happen, because the same changes happen in the left ventricle as with surgery. But there is not a huge exacerbation in respiratory support, and the babies do much better. So that has been our protocol. And I believe, Frank, you're in you're close to 55, 56 patients now, right?
I think we're at 54 so far.
So yeah, it has gone quite well. So of course we have the expertise of Dr. Ng, who I have heard that he can drive a truck through a needle hole. That's his expertise, but not everyone has that kind of availability of such expertise. So there is a learning curve involved here as well. But to answer your question, we haven't done any surgical ligations for over 3 years now.
Yeah, Dr. Frank, now some of the questions which we have is are you using only Piccolo now or not using the Medtronics one? Which one of the device is better? I think Dr. Satyan has partly answered this question about post complications following the occlusion, that we don't see much of, like the way we see post surgery, we see a lot of complications. With device closure, we don't see that. That's what Dr. Satyan said. So which device do you find is better? Do you have any?
It's a great question. We actually presented this comparison at a conference in May of this year at the SCAI, the Society of Cardiangiography and Intervention. And in looking at both devices, I actually think they're pretty equal. When we looked at our data, the patient profile, the PDA diameters, they were all pretty similar. The Piccolo device is definitely more radial dense, so you can see it better. Whereas the MPV is a lot harder to see. You're mostly looking at the two metal nubbins on both ends. On the other hand, the MVP is actually a smaller profile device. You can put it through a smaller system. The Piccolo is the one that is officially FDA approved. So there's at least some legitimacy in terms of having some official studies, whereas the MVP is done off label. It was actually designed for neuroradiology interventions in the brain. So you can imagine it was designed to be very small, very flexible to go through small vessels, but actually it has that application in the PDA. The delivery system for the Piccolo is slightly bigger, so it's a little more stiff. So one of the concerns I have is that when you run these catheters through the heart, there is a risk that you can cause a little bit of tricuspid regurgitation just because of how small the baby is. So I think right now, I don't really have one strong preference over one to the other because I feel very comfortable with the other. But because the FDA has approved the Piccolo device, more and more people are just going right to that just because that is legitimate. But actually, I think both have their advantages and disadvantages. I've had cases where when I put in one device and it didn't feel good or didn't feel right, I take it out and put the other one. And so to me, they're pretty much equal as far as effectiveness.
See, Frank, in some of the reports and other things, there have been some complications which have been reported with the device closures. What are the challenges you faced, and what are the risk factors for possibility of a device failure or a complications?
Great question. So again, because of 15 minutes, I didn't have time to present that. When we looked at our 54 cases, to me, there are some major and there's some minor complications. The major complications are going to be tricuspid regurgitation. Every once in a while, we've had 2 cases now. We actually tore a chordae within the tricuspid valve. So there was some tricuspid regurgitation. But actually, when we watch these kids over time, none of them actually, we're only talking about 2 patients, they all got better. Now, they did not all go away, but they actually got better and they never really needed anything as far as additional intervention at this time. But that doesn't mean that you cannot have a case where you tore more of the chordae. But this is why I think that as we're doing more of this, we have to pay a lot of attention as at the time when we're crossing the tricuspid valve. You can imagine if you're crossing through the valve and it's open, it's great. But every once in a while, you might get just crossed through one of the chordae and not realize that. So again, if you see that course is a little bit unusual, rather than just keep going, take it back and start again and try and make sure you go through the center of the valve. So that's one thing. We have now, because the babies, I'm always worried about head bleeds at this age. So as opposed to other cats, I don't give a bolus of heparin. What I do is I put heparin within the solution that I use to flush the system. So we're constantly giving small amounts of flush to make sure there's no clots. But I have had a patient where when I take pictures afterwards, I actually flushed out a clot into the RPA. Again, I have another lecture on tips and tricks. And this is one of the things that if you feel the resistance on that catheter, don't just overcome it, because all you end up doing is push a clot out. So luckily in that particular case, I can see the thrombus in the RPA by echo and fluoroscopy. We put the kid on 24-hour heparin, and the next day it resolved. So we were lucky with that. So again, we've all learned that now. Sometimes now, the more recent cases, I don't even take a picture after, because if the echo can show good flow, the angiogram just makes me feel better. So I'm treating myself. So nowadays, we don't really take a picture afterwards if we don't feel like there is if there is not a good a contrast, if there's any resistance in the catheter, we just take it out at that point. So there are some potential complications, and there is a learning curve, that Satyan said. And we've had a couple of patients who afterwards, the kid came back to the NICU with right upper lobe atelectasis. Now that's, I blame it on the anesthesiologist, but still that's part of the procedure complications that is incurred during the procedure. So again, we do pay a lot of attention to the respiratory system during the procedure. Early on, we had a neonatologist come down with us to help us manage the vent. Nowadays, they will come and help us, and they can leave and then come back if we need them. But certainly there is a learning curve, and both the neonatal and the cardiology services are work very closely. We have pre-procedure huddles to make sure that the specific needs of that child is met. We go through a whole checklist to make sure all the things we need are going to be available. We also have a post-procedure debriefing to see if there are any things we can do better to make sure that we're constantly improving. This is more of a QI project, but I think that for any institution starting this, they have to make sure that there are things that can be avoided, should be avoided, and that can only be done by rigorous evaluation before and after the procedure.
Thank you, Dr. Frank. Last question, because then we have to go on with the case is long-term follow-up, any long-term with the device, any long-term problems, or it's fine, there are no long-term complications?
So a long-term is a little bit vague in terms of what that means, right? So I know that some of the papers that's come out has more to do with neural development at 2-year stage. And so right now, all the patients we've done, they all go to the Mind Institute at Davis after graduation from the NICU. And so there is a project that we're looking at to see, can we assess these patients neurologically to see how they compare with those babies that did not have this procedure. So that's data's not there. But as far as the follow-up that I have for the device in the clinic, we've had a few patients where even if the PDA device is inside the ductus, depending on the anatomy of the ductus, there could be some external compression of the proximal LPA from behind where the ductus is located. Now, that can cause a little bit of a gradient across that, but we follow these patients over time. And as the babies grow, the somatic growth, as the vessels grow, the chest wall grows, that gradient goes away because the chest wall is bigger at that time. So I've not seen any problems. We have not seen anybody with residual shunts by the time they go to the clinic, and all the devices have remained very stable. So I've not seen any, at least technical problems in long-term follow-up. Obviously, the neurodevelopmental data will need some time to we'll figure out. Maybe next year you'll invite me and we can talk about that if we have more data.
In a nutshell, given data from these 55 patients, if you talk about respiratory morbidity at the time of discharge, remember these are really preterm infants, so we don't see, I can't say that we see huge improvements in outcomes. Their PDA is close, they do better, they go home, but we have had deaths in this series. We have had babies who had to go home on a ventilator. The incidence of chronic lung disease in these extremely preterm infants, even after a ductal ligation, is still pretty high. It's almost 2/3 of them have BPD. So it's very difficult to compare. And going back to the other question, long-term outcomes in comparison to surgical ligation, that's a tricky question to answer because there is a pre-post effect. We haven't done any surgical ligations simultaneously. So unless there is a randomized trial, that will be a very difficult question to answer. Briefly, I believe we will come to this later, but the post-ligation syndrome, we do see a little bit of LV dysfunction, but the incidence is very much low. I don't want to take up too much time, but I can later show you a figure. I really believe the post-ligation syndrome is not only due to LV dysfunction, but the morbidity of surgery itself. and that morbidity is not present when you do a cath-based ligation. So we do see slight exacerbation in settings because of transport and all those things in an extremely labile, very preterm infant, but we haven't seen a significant escalation of inotrope use after closure.
Can I just add one thing, Satyan? At least as far as I've seen for the patients we've had one death out of that 55 patients, and that the patient died months later, not related to the procedure, but other problems related to the prematurity.
Yeah, these are extremely labile infants, and so it's very difficult to link this procedure to those long-term outcomes.
And then as far as a cardiologist is concerned, we often look at x-rays, look at the flows, especially in left to right shunts. And as one of the slides I show you, you can clearly see the improvement in at least the pulmonary flow before and after. And we always measure the pulmonary pressures afterwards, and they're almost always subsystemic by that point. So whether that has a role in improving the pulmonary vascular development afterwards, we don't know that yet. Certainly there's still chronic lung disease, but certainly we are able to drop the pulmonary pressures and we're able to decrease the pulmonary flow. So at least from a radiologic point of view, you can see the improvement. So again, as a clinician, you can look at the x-ray before and after and ask yourself, what would you rather have? And most people would say, I'd rather have the picture of the x-ray afterwards. We're actually working, I'm trying to engage our radiologists now to do a quantifiable way to study pulmonary vascularity in x-rays before and after. I think it'll be nice to be able to somehow quantify the changes.
Thank you so much, Dr. Frank. I know there was a limitation of time. Looks like we should have had a complete session on transcatheter PDA closure. And thank you very much. I know you had to carry on to your cath lab, but please continue to join through the session. I know, and whatever questions come in. So I will now, Dr. Satyan, is it fine? We'll ask Dr. Ravi to moderate the session, ask his students to present the cases. Is it okay?
Yes, please. I need to log off in 45 minutes to go and start around. So I have 45 minutes left for now.
Yeah. Hi, Ravi. Yeah.
Yeah.
Frank, thanks again for joining us this morning.
Sure. I'm going to stay on for a few minutes and then I'll take off. I'll leave at 7:30.
Ravi, off to you. Please sort of introduce your students and start.
Thank you very, very much. Very good evening. We have come a long way in the management of PDA. There were days when we were treating PDAs only based on the clinical signs, and we were thinking whether we could see these PDAs by echo. And we have come a long way from that time, where there is a bedside echo available now in almost every NICU. But the problem is we are having more and more controversies regarding the treatment of it. So to present these two things, two of my fellows are presenting. Firstly, Dr. Punita will be presenting on the traditional practice of managing a PDA in a very low birth weight baby. The second presenter will throw some light on the controversies regarding the management of PDA in an extremely low birth weight baby. So first presenter will be Dr. Punita. Can you start, Dr. Punita?
Yes, sir. Good evening, everyone. This is Dr. Punita from Soumya Children's Hospital. I'm going to discuss when to treat a PDA. So fetal circulation is arranged in a parallel rather than in a series. So as the lungs are long functional in the fetus, the pulmonary vascular resistance is high. So most of the right ventricle output is directed towards the descending aorta through ductus arteriosus and is directed to arteriosus and is directed to the placenta for oxygenation. And most of the left ventricle output is delivered to the heart, brain, and other parts of the body. So when the cord is clamped, the placental circulation is eliminated. So there will be fall in circulating prostaglandins. This causes ductus arteriosus constriction. As the baby starts breathing, there is increase in PaO2. So this also causes ductus arteriosus constriction. This leads to neonatal translation. So what are the changes that occur after birth, circulatory changes? There will be drastic, rapid fall in the pulmonary artery mean pressure and pulmonary vascular resistance, and there will be rapid increase in pulmonary blood flow. So the factors that promoting structural closure of PDA are normally there will be a smooth muscle constriction and there is a prominent intimal cushion which helps in the ductal closure, and the platelet adherence to the lumen will be there. So there will be an obliteration and necrosis. But in preterm, there will be a generalized immaturity of smooth muscles and biochemical oxygen sensing mechanism. So they have fewer layers of contractile smooth muscle cells, and there will be absence of intimal cushions in the preterm ductus arteriosus, which is associated with failure to closure. Even they have lack of vasovasorum, which results in partial postnatal constriction without ischemic driven remodeling. So this will prevent in permanent closure. So the timing of spontaneous ductal closure is inversely proportional to the gestational age. If the baby is less than 26 weeks, it takes 2 to 3 months to close. If the baby is more than 30 weeks, it takes 2 to 3 weeks to close. When there is a left to right shunt, there will be a pulmonary overcirculation. So there will be a left atrial dilatation. This will cause increased LV preload, and there will be an increased LV diastolic pressure, which will compromise the coronary perfusion. And there will be an increased left ventricular output. So there will be in preterms, there is a low LV compliance and poor compensatory mechanism to handle such a large preload. So there will be an inadequate stroke volume, which causes inadequate systemic perfusion. The systemic underperfusion causes significant diastolic shunting in the distal aorta. So there will be a retrograde diastolic flow in the distal aorta. So there will be a compromised coronary perfusion, renal, mesenteric, and cerebral perfusion. So several observational trials have found that the odds ratio of adverse outcomes associated with PDA they are increased with like BPD, IVH, death are quite high with PDA. Risk factors for PDA are increased in extreme prematurity, antenatal magnesium sulfate, chorioamnionitis, RDS, and neonatal sepsis. And the risk is decreased with antenatal steroids administration. Clinically, when we can suspect there is a PDA, so the clinical signs which are suggestive are persistent tachycardia, bounding pulses which are palpable in dorsal pedis, and wide pulse pressure due to reduced diastolic pressure, common in preterm more than 1,000 grams. Hyperactive precordium due to increased LV stroke volume. And there is usually we may hear a murmur, but many infants with a large PDA may have no audible murmur. And oliguria and pre-renal failure, there will be a compromised renal blood flow. We can see there is a rising urea without a proportionate increase in serum creatinine. There will be a feeding intolerance because of bowel ischemia due to ductal steel or severe CHF with bowel ischemia. When when the baby is on a ventilator, then we have if we find that there is an increased ventilator settings, increasing oxygen requirement, and hypercarbia, and if we are unable to wean the baby from the oxygen CPAP or mechanical ventilator, then it is because of excessive pulmonary blood flow leading to pulmonary edema and decreasing lung compliance. And we have to look for even if there is a metabolic acidosis or recurrent apneas. These are the risk factors for PDM. So X-ray, we can find that there will be a cardiomegaly and pulmonary edema. Clinically, there is a distress score for PDA. The parameters which include are heart rate, murmur, precordial pulsations, peripheral pulses, CT ratio. And if the score is more than 6, it is suggestive of HSPDA. The definitive diagnostic test for PDA is color Doppler echocardiography. Echo also provides information about hemodynamic effect of PDA. When we do 2D echo, there should be a comprehensive assessment of hemodynamically significant PDA. So we have to look for the shunt size. There are three parameters which we have to look for: shunt size, pulmonary overcirculation, and systemic hypoperfusion. So the ductal characteristics will look the PDF in the short axis view, ductal view, and we'll look for the PDA diameter and Doppler flow direction, peak systolic velocity and systolic to diastolic velocity ratio. The ductal diameter is measured at its narrowest point before its entry into the main pulmonary artery. So when there is a pulmonary overcirculation, the left atrial enlargement will be there. So we have we have to measure the left atrial dimension comparing the aortic dimension. This will be increased when there is a pulmonary overcirculation. And the we can calculate left ventricular output by measuring the aortic diameter and also the aortic velocity time integrity. And LPR diastolic flow is increased, and this can be measured. The systemic hypoperfusion can be assessed in various systemic arteries where the diastolic flow will be decreased, absent, or reversed. This can be measured in superior mesenteric artery, celiac trunk, and descending aorta. There are even echo which correlates for HSPDA, which shows the small PDA, moderate PDA, and large PDA. If the diameter is less than 1.5, then it is a small PDA. If it is 1.5 to 3, it is a moderate PDA. If it is more than 3, it is a large PDA. And if the ductal left ventricular output is less than 314, it is a small PDA. If it is more than 314, it is a large PDA. LA-AVO ratio is, if it is less than 1.4:1, it is a small PDA. If it is 1.4 to 1.6:1, it is a moderate PDA. If it is more than 1.6:1, it is a large PDA. Systemic hypoperfusion, we have to look at the Doppler in the descending aorta. End diastolic flow is measured. If it is normal, it is a small PDA. Decreasing or absent, it is a moderate PDA. And if it is large, it will be reversed. There are studies on biomarkers which are elevated in HSPDA. The levels of BNP or NT-proBNP are elevated in infants with PDA and decreased after PDA closure. Elevated levels of NT-proBNP at 48 hours of age is associated with severe IVH and worse neurodevelopmental outcomes. Elevated plasma troponin T levels at 48 hours of age, it will correlate with echocardiography findings and death. These may be helpful to improve in diagnosis when there is no 2D echo available. So, coming to the case, this is the first case, the 31 weeks of gestation age baby with born to a primigravida mother whose antenatally the risk factor of preeclampsia. And in this case, the antenatal steroids are incompletely covered. Underwent emergency CS due to uncontrolled hypertension. The delivered a male baby with birth weight of 1.1 kg, cried after birth. We have started delivery room CPAP in view of labored breathing. In NICU, we have continued NCPAP with FiO2 of 35% and PEEP of 6. We have done a chest X-ray which is suggesting of moderate RDS. And at 3 hours of life, surfactant was given through insured method. Baby was hemodynamically stable at that time. On day 3, baby had tachycardia with heart rate of 165 per minute and pulses well felt. BP is 46 per 28 and CFT is less than 3 seconds. And systemic examination, it is normal. Blood gases and other investigations and supportive care is continued. So at that time, we have done a bedside echocardiography, which showed IVC normal. There is a left to right shunt across the PFO and good ventricular contractility. There is a tricuspid regurgitation and right ventricular systolic pressure was 35 to 40 mmHg. And the PDA size was 3 mm size with bidirectional shunt, and LA-AVO ratio is 2.01, LPA diastolic velocity is 0.33 meters per second, and cardiac output is 197 ml per minute, kg per minute. There is an antegrade flow in the descending aorta. So this image shows the Doppler flow pattern when the initial image shows that when pulmonary vascular resistance is high, the shunt will be bidirectional, and we can see a waveform on both the baselines, both the side of the baselines. And as the pulmonary pressure gradually drops, there will be a further left to right shunt, and the waveform below the baseline will decrease. The third C image shows that the typical left to right shunt, which is a pulsatile pattern, and D image shows us as it starts closing, we will have a pattern of sawtooth appearance, and ultimately it will disappear. So when there is a PPHN, the ductors can relieve excess stress on the heart by shunting blood right to left from the pulmonary artery to the aorta. And closing such a duct can lead to right heart failure. So in our case, as the echo is showing bidirectional shunt, there is a trigasmic regurgitation, pulmonary vascular resistance is high. So we have not treated this PDA. On day 6, this baby unable to wean. We are unable to wean the respiratory support as FiO2 requirement is increased to 40%, and baby had frequent desaturations requiring intubation and invasive ventilation. The heart rate at that time is 170 per minute, bounding pulses felt. BP is 52 by 20 mmHg, and mean of 32. There is a wide pulse pressure. Unit output is 1.2 ml per kg per hour. There is a systolic murmur heard on this left second intercostal space. Precordial activity was present. Other systems were normal. So this is the echocardiography, which is picture showing PDA. So at the time, the 2D echo findings are IVC is normal, PFO there is left to right shunt, PDA size is 4 mm with left to right shunt non-restrictive pulsatile flow, LA-AVO ratio is 2.4, LPA diastolic velocity is 0.5 meters per second, cardiac output is 336 ml per kg per minute. Anterior cerebral artery resistive index is 0.9 and absent diastolic flow in the descending aorta. So in our case, clinically the baby is symptomatic, and 2D echo is also showing HSPDA. So for every case, we need to give a supportive management to increase the pulmonary function. Those are, we have to restrict the fluid and optimizing the ventilatory strategies, like higher optimal PEEP should be given. We have to target the oxygen saturations to 90 to 95%, avoid excessive supplemental oxygen. There should be a permissive hypercapnia. We should avoid pulmonary vasodilators. Diuretics should be given to if there is a pulmonary edema or a heart failure. Correction of anemia and thrombocytopenia. Management of sepsis to decrease the capillary leak. Better nutrition to avoid hypoproteinemia. So in our case, we have given IV fluids 130 ml per kg per day, and septic screen was negative. Hemoglobin level and platelet count were within normal limits. So we have started a medical treatment with ibuprofen 20 mg per kg followed by 10 mg per kg on day 2 and 3. Repeat echocardiography after 3 days showed there is a closed PDA. So there are, we usually use for PDA 3 drugs, indomethacin, ibuprofen, and acetaminophen. So there are several RCT trials on these pharmacological agents.
Dr. Punita, can I interrupt you for a second?
Yes, sure.
Thank you for the great presentation. Before we lose Dr. Ng, Frank, can you address the question that Punita brought up earlier about what would you do as an interventional cardiologist when there is a baby with high pulmonary arterial pressures and a huge PDA? Can you briefly talk about that before you log off? Sorry to interrupt you, Dr. Punita.
Yes.
Sure, let me unmute. Well, I mean, as an interventionist, if you hammer, people say you should hammer, right? So I think that if you have pulmonary hypertension and you have a big ductus, I think the main question is that I, as a cardiologist, understanding the hemodynamics would close them, especially if there is a safe and effective way of doing it. Obviously, what I don't know is if you left it alone, can this PDA just close without prolonged respiratory support? And I think a lot of that is going to be based on whether you, as a neonatologist, can continue to wean the ventilators, and is there a progression with the clinical presentation? But certainly, knowing what I know now, knowing the results we can get, I would take him to the lab and close a large PDA. But again, I think that this is not a decision that I should make alone. It should be made as a team, especially with the neonatologist leading that team.
Can you briefly comment about your ability to measure pressures with during Cath versus inability to do that with conservative management, with medical management?
I know that on the echo, if you have, I mean, a lot of these patients can have pulmonary hypertension, not just from high flow, right? I mean, there's a lot of other reasons for that as well. But certainly on the echo, unless you have a little bit of a TR jet, it's hard to quantify the RV pressures. So then we rely on the bowing of the interventricular septum. In the normal heart with low pressures, low pulmonary pressures, during systole, the left ventricle pressure is higher. So therefore, you would expect the left ventricle, the interventricular septum to bow from left to right. But when there's pulmonary hypertension, as the pressure goes up, the septum will flatten out. And in fact, it can bow right to left when it's very high. So in the scenario where you can't quantify it and you know the ductus is big and on x-ray you see the lung markings, those are some of the ways you can clinically decide that there is. Now, once we're in the cath lab, it's easy. When I put a catheter in there, I can easily measure those pressures. I don't always do it now because it won't change my decision, but I will measure it at the end to see what those numbers are, to at least help guide some of the management afterwards. So usually by the time the decision is made to go to the cath lab, I'm not so sure it's that absolutely necessary to measure the pressure ahead of time, only because when we run the wire through, we already run the wire through the ductus in the descending order. Once we put our catheter there, in order to measure the PA pressure, I have to pull it back into the pulmonary arteries, which means I would have to then go run the wire back through afterwards. So that just takes more time, more fluoroscopy. And so we've learned now that it's probably easier just to measure your pressures afterwards on the way out of the heart.
Dr. Frank, that's quite interesting. See, if you look with some of our cardiologists, when there is a bidirectional shunt, they're a little hesitant even for medical treatment. They say, let's wait for the pulmonary pressures to drop.
And that's a very fair point. So when we don't do this with bidirectional shunting. So I think that's a very fair point. The worry is that if you actually have other reasons besides just the flow, you get rid of that ductus. Now you suddenly have no pop-up. So I think that that's a very good point, that we don't want to close this if there's bidirectional shunting.
Okay.
Thanks, Frank.
Thank you, Frank. Dr.
Thank you.
Satyan and Punita, I think, Dr. Satyan, I think everyone wants to discuss a lot of questions with you. I know you're short of time.
I think she has just 5 more minutes to present, and then we can have a discussion with Professor Satyan. Is it okay?
Yeah.
Of course. Thank you. Again, sorry to interrupt. Thank you. Please continue.
So the drug's dosage, indomethacin dosage was infants less than 48 hours of age. First dose is 0.2 mg per kg, followed by 2 additional doses of 0.1 mg per kg, given at 12 hours interval. And infants more than 48 hours and less than 7 days, 3 total doses are given, and like 0.2 mg per kg per dose, given at 12 hours interval. And infants more than 7 days of age, 3 total doses of 0.2 mg per kg per dose is given. There is less risk of IVH with etomimethacin, and complications, there is increased risk of NEC, bleeding, transient renal insufficiency, intestinal perforation, especially if given along with steroids and connectors. It is contraindicated in sepsis and active bleeding, thrombocytopenia, NEC, renal function impairment, and congenital heart disease where patency of ductus arteriosus is necessary. In ibuprofen, there are 2 doses, standard and high dose. Standard 10 mg per kg followed by 2 additional doses, 5 mg per kg given 24 hours interval, and high dose is 20 mg per kg followed by 2 additional doses, 10 mg per kg given 24 hours interval. There are studies shows that high dose is more efficacious than the standard dose, and the benefit is it is as effective as indomethacin. There is a low risk of NEC and transient renal insufficiency, and the complications and contraindications are same as indomethacin but with little incidence. The paracetamol, the dose is 15 mg per kg given 6 hourly for 3 to 7 days. If the baby is less than 28 weeks or less than 1 kg, the loading dose is 15 mg per kg, maintenance of 7.5 mg per kg dose given 6 hourly. There are less adverse effects compared to other NSAIDs, and the complications are hepatotoxicity and ADHD. This chart shows efficacy of pharmacological treatment to close the PDA comparing the paracetamol and NSAIDs. And the stripped box shows the paracetamol and the clear box shows the NSAID. The efficacy of the drug decreases with the increasing postnatal age. The postnatal age on day 1, the efficacy is same with the NSAID and paracetamol being 80%. And if the postnatal age is crosses more than 7 days, then the efficacy is decreasing with both paracetamol and NSAIDs. And if the baby is less than 26 weeks, the efficacy of paracetamol is very poor. The next case is a 29-week female born to primary mother. There is a history of leaking per vagina for 14 hours, followed by spontaneous vaginal delivery with birth weight of 1,000 grams. And the baby required PPV for 1 week and it was shifted to NICU with delivery room CPAP. The baby is given 1 dose of surfactant in view of RDS, and we have started empirical antibiotics for sepsis. On day 2, we have done a 2D echo which showed hemodynamically significant PDA. So we have started IV paracetamol. As baby had brown color OG aspirates, it was given for 3 days. Day 3, there is increase in RD and FiO2, so we have mechanically ventilated the baby. On day 5, baby was still on mechanical ventilator requiring a FiO2 of 35%. Heart rate is 165 per minute. The palpable dorsalis pedis. Systemic examination CVS showing systolic murmur heard on left second intercostal space and precordial activity present. So for the response to therapy, we will do a 2D echo 24 to 48 hours after completion of the treatment course. Has few infants failed to respond to an initial dose of COX inhibitors. In this case, the echo findings showing a hemodynamically significant PDA. So we have given a second course of pharmacological treatment with oral ibuprofen for 3 days, as baby is tolerating feeds at that time. The risk factors for persistent PDA after first course of pharmacological treatment are lack of exposure to antenatal steroids, severe RDS, intrauterine inflammation. Limited data suggests that second course of COX inhibitors therapy is associated with 40% rate of ductal closure in infants who fail to respond to initial therapy. So it is reasonable for us to start a second course in these days. So if infants fails to respond to 2 courses of therapy, no further medical therapy is given. Treatment failure indomethacin babies are much more likely to die before hospital discharge than those whose ductus closes without treatment. Persistent PDA after treatment was associated with an odds ratio of neonatal death of 12.3 versus infants with spontaneous closure. On day 8, in our case, the baby was requiring still invasive ventilation with FiO2 of 40%. So repeat echocardiography also showing the hemodynamically significant PDA with cardiac output increased to 416 milliliters per kg per minute, and the PDA size also increased to 5 mm. So we have surgically ligated this case, and at post-operatively after 6 hours, the baby condition has deteriorated. The ventilator support requirement is increased to 60% from 40%, and pressure were also increased. And then baby had hypotension with BP of 30 by 18. So we have suspected a post-ligation cardiac syndrome, which is a left ventricular dysfunction, which occurs within hours after surgery. The complications of surgical ligation of PDA are post-ligation cardiac syndrome. There will be a compromised cardiac output when it is ligated. There will be a sudden LV exposure to systemic vascular resistance, so there will be an increased afterload, and ligation reduces the pulmonary venous return, which causes reduced preload. Preterm myocardium is stiff and relaxes poorly. There will be a diastolic dysfunction, and preterm myocardium does not tolerate increased afterload, which causes systolic dysfunction. So the other complications of surgical ligation are pneumothorax, chylothorax, recurrent laryngeal nerve palsy, phrenic nerve palsy, and diaphragmatic weakness, and prolonged ventilation (BPD), and there will be inadvertent ligation of left pulmonary artery or left main bronchus. So at 1 hour, we have to, after post-op, we have to do a 2D echo. If the left ventricular output shows less than 200 ml per kg per minute, we have to suspect that maybe is getting deteriorated. So we have started milrinone for this case. And if it is still persisting, depending on the left ventricle, like systolic hypotension or diastolic hypotension, we'll start the inotropes and we'll give hydrocortisone. Several studies have shown that there is poor outcomes after surgical ligation. No?
Dr. Punitha, can you just wind up, because I think
Yeah.
we have just time for discussion. So if it is case is over, let's start discussing, because I think we have very less time with Satyan. So if you case is over,
yes, the last two slides.
Yeah. Let's start the discussion.
Several studies have shown that there is poor outcomes after surgical ligation, not because of ligation, but because baby remain on ventilator for longer time. So we have observed that there are long-term morbidities like severe ROP, CLD, but there is less chances of death. Transcatheter closure of PDA, the much safer way to close transcatheter ligation. So this is already dealt by the expert talk, and conclusions. Most of the ductus arteriosus will close spontaneously and hemodynamically. Significant PDA has been shown that significant adverse outcomes. And closing a symptomatic PDA is the commonly practiced strategy at present and probably has short-term benefits. Efficacy of the medications used in the management of PDA decreases after 1 week of life. Surgical ligation is the last option, but it carries complications. Transcatheter device closure is the safer. Thank you, sir. The next case will be dealt by my colleague, Dr. Shravan.
No, I think we'll wait. I think we have Dr. Satyan to make his comments. And sir.
Dr. Punitha, that was a wonderful overview and two really challenging and very nice cases. And Dr. Yadav, I will need considerable help from you in dealing with these questions, because my approach is very biased in this institution, at least for the last 3 or 4 years, thanks to having access to transcatheter closure. So there are several questions here. I will try to address them from one end to the other. Many have asked as to what protocol we use in our institution for PDA management. I will have to say that this has been an extremely controversial area. Not a week goes when Frank and I are having heated exchanges in the middle of the unit, arguing about who should be closed, who should not be closed. So we are in no better position than where you are in this particular instance. So what we do is we try to avoid getting an echo unless the baby has significant hemodynamic compromise for the first few days of life. And typically we wait till day 6 to 7, depending on the weekends when you can't get too much done. And then we get an echo done at that time and assess the size of the PDA. If the PDA, and before that, we do use in extremely preterm infants, 26 weeks and lower, less than 26 weeks, we do use indomethacin prophylaxis at 0.1 per kilo per day for 3 doses. Because as one of the questions pointed out, it does reduce IVH and has some short-term benefits at least. So we do use indomethacin prophylaxis in extremely preterm infants. And subsequently, if the ductus is still open at day 6 or 7, we go through one course of therapy. Our hospital does not stock IV ibuprofen, partly because there have been some instances where there have been errors in dosing with having indomethacin, which has the dose of a minute fraction of that of ibuprofen. So there are 2 medications starting with I and following one error many years ago, we have decided only to have one medication IV, which is IV indocin and or IV acetaminophen. So we go with IV indocin if there are no contraindications, and the contraindications mainly being renal failure, any suspicion of spontaneous intestinal perforation, and of course, intraventricular hemorrhage, grade 2 or higher. And we avoid using indocin in those cases and prefer IV acetaminophen. And our doses are very similar to what Dr. Punitha showed. We use a similar doses in these instances. If oral therapy is an option as well, in those cases, we do, of course, use oral ibuprofen. That everybody has access to that medication. Subsequently, after the first course fails, if the baby is still on significant respiratory support, the protocol we use is where we use either invasive mechanical ventilation or non-invasive mechanical ventilation with significant FiO2 requirement. So we use one of those scores used by one of the studies that Dr. Punitha showed, Dr. Madan et al., that has a respiratory score assessment. We use that where you multiply FiO2 with a factor based on the type of respiratory support, and then add medications that the baby is on and use that as a cutoff for deciding whom to treat and whom not to treat. And if the baby does meet requirements following a first course, most of us get a consult with Dr. Ng, who comes and talks to parents about transcatheter closure at that time, and we go that way. So that's the protocol that we use in our unit. Dr. Yadav, I'm curious to hear your thoughts on these questions.
Thank you, sir. Am I audible now? Am I audible?
Yes, yes.
Yeah. As far as Indian scenario is concerned, there is not much of in-house cardiologist actually available. So we cardiologist actually visiting cardiologist. So in this scenario, clinically, how to pick up PDA becomes quite important. So I would like to ask Punitha, especially about blood pressure. Is wide pulse pressure is one of the important signs of hemodynamically significant ductus. So what is your idea about wide pulse pressure? When to call it wide?
When the diastolic flow is there is runoff, there will be a wide pulse pressure is increased, sir.
No. Like when to call pulse pressure to be wide? Because because of this one, many times we diagnose PDA, retrospectively we feel that yes, it was like this. So wide pulse pressure is no uniformly accepted definition. The rule of thumb, what we can follow, is the difference between systolic and diastolic. That is pulse pressure. Pulse pressure and diastolic pressure, if you compare, the diastolic pressure is much more than this pulse pressure. It's called wide pulse pressure. Sorry, diastolic pressure less than that. For example, in your first case, initial pulse BP was 46/28. Later on, when we had trouble, it was 52/20. So difference has become quite wide. Difference more than diastolic can give you a first hint that actually something is not right. And at that time, actually, we can involve cardiologist earlier. This one. This is one point I want to make. Second thing is regarding size of ductus. Size of ductus less than 1.5, 1.5 to 3, and more than 3 is traditional way of classifying mild, moderate, severe ductus. But now we are seeing a wide range of birth weights, right, from 350 to 1.5. So that particular ductal size should be in context of the weight of the baby. For example, we can do a ratio between weight and the size of ductus. According to some people, that ratio, if more than 1.4, then we can consider to be actually a big ductus. Another interesting thing you told about the pro-BNP, because of COVID pandemic, the BNP use in NICU is increased now. BNP, previously this was not a routine investigation in NICU, but now more and more NICUs are using pro-BNP to find out the search for COVID. So what do you think is the relationship of this pro-BNP and PD?
The left atrial enlargement will be there. So the pro-BNP will be increased when there is a left atrial enlargement.
So when we went on doing this pro-BNP in so many babies, we found predominantly 3 reasons why this pro-BNP increases. One is atrial dilatation can happen secondary to widespread alveolar collapse itself. Second reason is hypervolemia. It's hypervolemia itself stretching the atrium. And third reason was cardiac dysfunction. So with this pro-BNP can prove a good marker in future for this atrial stretch. Because at present the cardiologist is very difficult to find, but pro-BNP is very easy to do. So this pro-BNP in future, so if we keep on monitoring hypervolemia, stretching of atrium, the sign of valvular collapse, all those things, we can do it in a better way. These are the few points I want to make. Over to Satyan.
Dr. Satyan, see, what I have to say is in India, a lot of people seem to be sort of easily moving on to paracetamol, acetaminophen lately with all available evidence, because we don't need that FDA approval as much as you guys need. So we quickly embrace the paracetamol. I know you're short of time. That's why I'll probably use you more in whatever time you're available with questioning you rather than, because we can continue with this. Question is, do you routinely do echoes in all your extremely low birth weight and preterm babies? And if you do, at what age? Or do you wait for any clinical signs to develop?
We do not routinely do echocardiographs in all babies unless they're 26 weeks or less. Otherwise, we do not do it. And in those babies, if there is hemodynamic compromise or pulmonary hypertension, of course, we do it early. If not, we wait till day 6 or 7 before we do the first echocardiogram.
So the second thing is, see, now hemodynamically significant PDA, if you look at the review, there are a lot of, some people have scoring system and other things. Do you have a specific scoring system you follow to say it's a hemodynamically significant PDA, as Rahul has pointed out, because the size of the PDA could be age dependent, there are flow velocities are there. So do you follow any scoring system, clinical score or echo score, or you just go by overall parameter that the treating consultant feels I should treat it?
We typically follow somewhat the McNamara score, which is similar to what Dr. Yadav mentioned. The size of the PDA is a little tricky because it does vary with the size of the baby. So our echocardiographers, I don't remember the exact mechanism, but they compare it with the pulmonary artery and use that comparison as a proportion to dictate the size of the PDA. We don't go by absolute measurements because, as Dr. Yadav pointed out, a teeny 450 gram versus a 1.2 kilogram, there might be variation in size. So we use it as comparison with the pulmonary arterial size. One other point I would like to make is this controversy about coexisting pulmonary hypertension is a major one. And in fact, we have babies in the unit with a large PDA who are on inhaled nitric oxide because we can't oxygenate them. So as we talked about this earlier, and I was very intrigued as to what Dr. Punitha would do with the first case, where you see some amount of tricuspid regurgitation, evidence of pulmonary vascular resistance, and a combination of a large PDA. As we know fully well, increased pulmonary arterial pressure can be due to two causes. One is increased pulmonary vascular resistance due to restrictive flow due to vasoconstriction or remodeling of the pulmonary vasculature. Second, it could be due to hyperdynamic pulmonary flow itself that can cause increased pulmonary arterial pressure. And it's very important to differentiate between the two, which we really can do by echocardiography in many areas, because if you're dealing with a hyperdynamic pulmonary overcirculation, closing a PDA might be beneficial. In fact, one of the risk factors for BPD and pulmonary hypertension is presence of a prolonged persistence of PDA or a PF4 and ASD. Increased left to right shunt in a patient with existing BPD is a big risk factor for BPD with pulmonary hypertension. So that creates a bigger controversy. I'm sorry I cut off Dr. Ing earlier, but he has some slides mainly coming from Memphis and other areas which have shown that if you leave a PDA for long periods of time without doing any closure in the presence of significant BPD, there is increased risk of pulmonary vascular remodeling. And so that is a bigger concern that we need to consider as well when we think about closing the PDA or not closing the PDA. So it's not as easy to dissect as many of us have realized. And this is a subject of great controversy, and each case is very unique unto itself. So there are many times when we violate our protocol and use pulmonary vasodilators in some of these patients because we just can't oxygenate these babies due to high degrees of pulmonary hypertension.
Can I also make a point? This is Franklin. I'm driving, so you might not hear me as well. But another reason, as Dr. Satyan said, we have this formula, P equals QR. That means pressure equals flow times resistance. And so in the setting with a combination of high resistance and high flow, if you get rid of the PDA, you can actually be more aggressive with your pulmonary vasodilator therapy. Because if you leave the PDA alone and you drop the resistance, that just increases the left to right shunt. So therefore your pressures will still remain high. So in the setting where you have left to right shunt, but still have some resistance issues, getting rid of that shunt can drop your pressures. And then you can also be more aggressive with using your pulmonary vasodilator therapy.
Okay, thank you. Dr. Satyan, one of the thing is, you look from the Japanese protocol or some of the Austrian protocol about early targeted therapy, looking at the duct early closing off, and you talk about, I looked at some of the units which wait for a week and then start. So do have a very restricted fluid therapy in the first week? Did you have a problems of pulmonary hemorrhage or something like that in the first week when you took this approach? That was first question. And second is, this indomethacin prophylaxis, is this only for the less than 26 weeks you follow? This is something which we need to clarify to all the delegates.
There are significant differences in management between US and India and Australia as well. For some reason, I do not know why, but the incidence of pulmonary hemorrhage in the US is very, very low. We do not see the high incidence that's reported in Australian and New Zealand networks for some reason. And I do not have an explanation for that. It's been, I think I've seen one case of pulmonary hemorrhage, significant pulmonary hemorrhage in the last 10 years. So it's extremely unusual here. On the other hand, our incidence of SIP or spontaneous intestinal perforation with indocin is very high. I think the difference is the rate of antenatal steroid use in the US is very high in my unit, reaching close to 94 to 95% among extremely low birth weight infants. And so because of that high incidence of antenatal steroid use, the influence of that plays a role in how we manage these infants. It's controversial as to whether SIP is more common with indocin combined only with postnatal steroids, or if antenatal steroids plus indocin also increases the risk. There are studies showing both, and I truly believe that a combination of indocin and antenatal steroid therapy, especially close to the time of delivery, also increases your incidence of SIP. So that has partly dictated our management here, and that's the reason why we restrict indocin to a very low birth weight infants. As you all know, the TIP trial showed huge decreases in IVH and short-term outcomes, but no difference in long-term outcomes, especially at school age. So that brings up to the question as to what are we treating? And so if there is 1 minute, I want to show one slide before I hang up, just because this has two important points. So one is, this is the one that Frank was talking about, and I thank Frank for providing these data. So if you have already a vessel that's remodeled and has significant remodeling, pouring extra blood either through an oval foramen or through a PDA will exacerbate capillary leak, pulmonary edema, and worsen remodeling and increase pulmonary venous hypertension. And in fact, here is a radiograph from one of Dr. Ng's patients. Here you see that in patients who are early in the course with a PDA, when you do a Cath, you see this nice blushing pattern showing that pulmonary vasculature is really well formed. But in some areas, in some patients, you see that this is this pruned approach where the minor microvasculature is not very well formed at all, showing that there is already pulmonary vascular disease. So this gives you another indication as to what this baby is prone for. And in neonatology, we are in a really odd situation right now because there is a common sense based approach, which as an Indian, I do every single time because that's how we were taught, using physiology and common sense. But with more newly, the approach is evidence-based, and every single thing that we have seen, for example, resuscitation of extremely preterm infants with differing levels of oxygen, it makes a lot of sense to use low O2, but we are seeing that using 21% O2 for extremely preterm infants may not be as good as in term infants. The second thing is the oxygenation trials have shown that, I really thought when we were entering these neoprom trials that 85 to 89% oxygen would be much better than higher O2, but low oxygen was associated with higher death, which was very surprising to me. The SAIL trial, which showed phenomenal results in animal studies, did not show good results in human studies. And more recently, the placental transfusion trials, especially milking trials, have shown that there is increased incidence of IVH with milking in extremely preterm babies. So there are all these trials which clearly show that what we think of things using common sense and physiology may not really translate to evidence-based medicine. And for this reason, we should be a bit careful adopting these therapies in the absence of good randomized controlled trials. And given the restrictions that are posed by FDAs and IRBs in the US, I think you all are very poised to conduct these trials in a much more effective fashion. 1 out of 8 births in the world happen in India right now. So you guys have a lot more ability to do these trials than we do. And I think it'll be great if you come up with a good PDA trial. There are so many PDA trials going on in this country, and they're having a hard time recruiting patients because of lack of equipoise. And I think it will be great if you all can come up with some nice studies to answer these questions. I'm going to log off soon unless there are burning questions. And I really thank you for this opportunity.
Dr. Ravi, do you want to,
Yes.
Manoj, you said, I think, do you want to sort of ask anything before Satyan logs off? And then we can.
No, nothing. Professor Satyan, it was as usual. You are. It's so satisfying to hear you. Like, thank you so much.
Thank you. Thanks again, Frank. Thanks for joining. I really appreciate you joining us this morning, and thank you for all the
Thank you, Satyan. Thank you, Frank, and thank you for excellent discussion and sharing your experiences. And
thanks to Dr. Punitha for the wonderful presentation. I'm sorry I couldn't hear the other trainees' presentation. Have a great day and have a nice weekend.
Thank you.
Bye. Bye.
Yeah. Thank you. Ravi, can we go with the second presentation, please?
Yes. Shravan, can we have the second one?
Yes, sir.
So I think it is on the same thing as issues what many of the attendees have been asking about the controversies related to the Pdm management. Please start, Shravan.
Good evening, all. And now I'm going to discuss the PDA management in extremely premature babies. So I'll directly start with the case. A G2P1L1 mother came with the spontaneous onset of labor, and a female baby was delivered by spontaneous vaginal delivery at 26 weeks of gestational age with birth weight of 680 grams. And immediately after birth, there was no spontaneous respiratory efforts, and baby was flaccid, required resuscitation and required intubation, and was initiated on mechanical ventilation. And chest X-ray was suggestive of RDS, and 2 doses of surfactant was administered for this baby. And this 26 weeks, 680 grams neonate with severe RDS, and this neonate is at high risk for morbidities associated with PDA. So what are the morbidities associated with hemodynamically significant PDA? Are prolongation of assisted ventilation and higher rates of death, incidence of BPD, and incidence of pulmonary hemorrhage and severe pulmonary hemorrhage and NEC, impaired renal function, intraventricular hemorrhage, periventricular leukomalacia, and cerebral palsy. And data from the DETECT study suggests that the large PDA diameter of having more than 50th percentile of age in the first 12 hours after birth is associated with pulmonary hemorrhage before 72 hours of age. And so how should we treat this PDA? So what is the best strategy to avoid all these consequences due to PDA in an extremely premature baby? So now we are going to discuss about the different strategies for PDM management, which includes the symptomatic treatment and pre-symptomatic treatment, conservative management, prophylactic, and early targeted managements. And coming to first strategy, so in babies, after occurrence of the clinical signs and symptoms such as bounding pulses and wide pulse pressure, hyperactive precardium, and murmur, so treating with management, the outcomes observed in RCTs of intravenous indomethacin was there is significant ductal closure was observed, but there is no other beneficial effect with the other parameters such as death rates and incidence of BPD, oxygen requirement, and incidence of NEC, SIP, and sepsis. And coming to the long-term outcomes, like there is no significant beneficial effect for cerebral palsy. And our second strategy, the pre-symptomatic treatment, in which we, before occurrence of the clinical signs and symptom, treating the baby with the with with pharmacological management in first 3 to 5 days of life. The outcomes observed were the ductal closure was significant, but similar to the symptomatic treatment, there is no beneficial effects in other outcomes. And some believe that not treating the PDA and promoting, like using supportive measures by treating with supportive measures, and several reports provide reassurance that adoption of less aggressive management strategies is consistent with favorable outcomes. And these outcomes comparable to those reported to multi-center collaboratives were achieved using conservative management. And in one study by Van Seabrook et al., and 13 units were enrolled in less than 30 weeks of gestational age who were ventilated and required surfactant replacement, and 33% were having PDA, and these 33% babies treated with the conservative management with fluid restriction and ventilatory adjustments. In those 33%, all units PDA were closed, and none were required ductal ligation. And in another study, 280 neonates out of 368 very low birth weight infants received truly conservative PDA management, and in that 85% of non-treated infants, the PDA closed before hospital discharge, and in remaining 15%, PDA closed spontaneously after discharge at 1 year, and one neonate required the device closure and one unit required surgical ligation. And then the question arises, we have to treat the baby mandatorily, treat the PDA mandatorily, or by using non-interventions with no treatment. And Sung et al. Reviewed medical records of 178 infants of 23 to 26 weeks gestational age with PDA and requiring ventilatory treatment with hemodynamically significant PDA. And they took the data of 2 years retrospective data and 2 years of prospective data. This retrospective data constituting mandatory closure, and in prospective data, they have done nothing, and they have used the non-interventions. And in mandatory closure group, 82% of neonates were ultimately required the surgical ligation. Surprisingly, in non-intervention group, no neonate was treated with indomethacin or surgical ligation. And the average postnatal day of PDA closure in the mandatory closure group was day 13, and in non-intervention group was day 44. And there was significantly more use of diuretics and fluid restriction was observed in the non-intervention group. And interesting thing is, there was no difference in mortality or IVH or incidence of NEC or BPD in the both groups. So our next strategy is prophylactic closure of PDA. And in this closure of PDA, either medically or surgically, in all units at risk for PDA in the first 24 hours of life without echocardiographic assessment and regardless of its hemodynamic significance. So the prophylaxis, indomethacin prophylaxis for PDA, the outcomes observed in RCTs, they're showing that early treatment with IV indomethacin or placebo beginning within first 6 to 12 hours after birth, there is significant reduction in the rate of persistence of PDA and rates of IVH and IVH above grade 2 and PVL. And also observed significant reduction in the frequency of early and severe pulmonary hemorrhage after prophylaxis. And there is no improvement in other outcomes with the prophylactic endomethacin. And these prospective data from 35 hospitals from neonatal research network registry of less than 29 weeks and less than 1 kg babies, in which the babies treated with prophylactic indomethacin, 21% of babies required rescue PDA treatment, and in non-treated babies required 36% of rescue PDA treatment, and more than 3-fold reduction in the BPD and 2.8-fold reduction in the rates of death observed with the prophylactic usage of indomethacin. And ibuprofen prophylaxis for PDA, the outcomes observed in RCTs, there is significant ductal closure rates were there, but no beneficial effects in all other outcomes. But there is significant increased incidence of sepsis with the ibuprofen prophylaxis for PDA. And acetaminophen prophylaxis for PDA, there are two recent small placebo-controlled trials have evaluated prophylactic use of acetaminophen, and acetaminophen appears to have some efficacy for accelerating ductal closure, and other effects were not statistically significant compared to the other two pharmacological agents. And finally, the long-term beneficial effects of ductal closure have not been demonstrated with any treatment or prophylactic strategy to close the PDA in preterm infant. And also, data regarding conservative approach is insufficient in our baby. So at 24 hours of life, baby was on invasive ventilation with minimal ventilatory settings, and heart rate 142 per minute, and pulses normally felt, and BP was normal for the age, and precardium was normal, and echocardiography performed at 24 hours of life. Echocardiography showed a transductal diameter of 2.4 millimeter with ductal Doppler showed non-restrictive pulse style flow, and with the LAO ratio of 1.2 and antegrade diastolic flow in the descending aorta, and LV output was 300 ml per kg per minute. So now our next treatment strategy comes that early targeted treatment, in which we treat infants based on echocardiographic parameters prior to the duct becoming clinically significant. So what is the basis for this early targeted treatment? So waiting for spontaneous closure of PDA implies acceptance of any long-term consequences of a PDA. So the adverse effects of PDA are probably related to the amount of time the infant is exposed to the left to right shunt. So for each individual infant, there will be a different risk-benefit ratio. And also, there is studies say there is significant negative association between duct diameter and SVC flow at 5 hours of life, which is a surrogate marker of systemic blood flow. And there is also a significant association between early low systemic blood flow and development of IVH and later NEC. And this suggests a possible mechanism by which PDA shunting might play an important role in pathophysiology of these conditions. So therefore, early treatment of significant ducts might prevent the morbidities associated with PDA, but till date, there is no proper evidence. We are lacking the evidence to say this. And what are the real targets to treat using the echocardiography are the babies who are born less than or equal to 26 weeks, and who are these babies are most vulnerable to the both short-term as well as long-term adverse effects of the PDA. And by using echocardiography parameters, by using PDA diameter measurement and low pattern assessment, early echo may identify large and non-constricting PDAs which are unlikely to close spontaneously, thus reducing the duration of the time spent in a hemodynamically compromised state with the associated risks of adverse outcomes. And a study by Martin Kluckow, the DETECT trial, the famous DETECT trial, ductal echocardiographic targeting and early closure trial, in this with the usage of ultrasound parameters and treating the PDAs, the target treatment to the PDAs will decrease the adverse effects of the pharmacological agents, and also will give more benefits. And the recent Cochrane reviews, 2020 Cochrane reviews, the early versus expectant management of PDA, early treatment which was initiated by 7 days of age and versus expectant management showed that there is no difference for all-cause mortality and the morbidities caused by PDA, such as surgical PDA ligation and chronic lung disease, severe IVH and NEC. And with the very early treatment initiated, which was initiated by 72 hours of age versus expectant management, also showed there is no difference for all-cause mortality and morbidities associated with the PDA, but there is shortened the duration of the hospitalization of the baby. So, what are the different timings for the intervention? So, the early closure of the PDA will have, with the early closure of PDA, we can prevent the development of comorbidities like hypotension, pulmonary hemorrhage, IVH compared to the using late treatment. And summarizing the treatment modalities of PDA. So with the usage of prophylactic treatment, there is significant reduction in the PDA rates and decrease in IVH and pulmonary hemorrhage and need for the surgical ligation. But with prophylactic treatment, there is increased risk of exposing the babies to the pharmacological agents. And with the early targeted treatment, which we do echo based, we start in first 24 hours, and with these the PDA closure rates are high, and decrease in IVH and pulmonary hemorrhage also high, and the need for surgical ligation is less, and it decrease compared to the prophylactic treatment. It decreases the unnecessary treatment for PDA. And the early symptomatic and echo based treatment which show the promising results of PDA closure and decrease in IVH and pulmonary hemorrhage, and the need for surgical ligation, and also decreases the prophylactic decreases the unnecessary exposure to the pharmacological agents. And also the symptomatic treatment which was given later after occurrence of the clinical signs and symptoms, there the increased risk of NEC was observed, and with no treatment or conservative treatment, the rates of NEC and increased rates of mortality were observed. And as of now, the echo-based early targeted treatment, there is no strong evidence till date, and but the results are promising. And with the early symptomatic treatment, echo-based early symptomatic treatment, also the results are promising. So finally, there is uncertainty regarding which babies with PDA needs treatment due to high spontaneous closure rates of PDA and variable efficacy of the medications available, and failure of trials to show clear short and long-term benefits. And when we are thinking of PDA management, it should be individualized based on pathophysiology, and the bedside functional echography is important in the selection of patients for treatment or no treatment, and subsequently the overall management of PDA. Thank you.
Thank you, Shravan.
Thank you, sir.
Thank you for your excellent presentation. Can we have some, we'll start with some questions. We have one question. The TRIP trial decreased severe IVH with prophylactic treatment. So yeah, they're talking about a TRIP trial. Rahul, do you just want to answer this about the TRIP trial? Are others there?
Can you hear me now? Can you hear me, Shravan?
Yes, sir.
Yeah. Your presentation was very nice, actually. You compared all these various strategies and all. So at the end of the day, the audience may be actually more confused about what strategy we should follow. Means you actually, after all the strategy, it boils down to only one thing: is individualization. You told that early therapy will ensure ductal closure better. Later therapy ductal closure will be less effective. But early therapy also carries out a lot of risk factors with that. Sometimes baby dies, sometimes we say in spite of treatment baby dies, or whether it is because of the therapy baby died. That is eternal question every clinician faces. So you nicely put that very important slide that you should be individualized, checking out the equation between risk and benefit. Individualization, equation between risk and benefit. So I would like to ask you, individualization exactly what you are implying. Means suppose you are a preterm baby is there, we do echo. Echo shows some diameters and some centimeter, millimeters, and all those things. And babies are requiring some oxygen and all those things. So pointed question, whether to close or not, very difficult to answer. I agree. But what are the factors you will consider before deciding to give paracetamol? Individualized baby. No, not about any trial, not about any study or something. Individualization of that particular baby, whether you go for paracetamol or wait for some more days. What are the factors you will consider?
Sir, it depends upon the baby's gestational age and baby's clinical condition. If clinical condition is worsening and the duct is becoming hemodynamically significant, so as with repeated serial echocardiographies, if we have the echocardiography in our unit and with the serial echocardiography, if the duct characteristics are rapidly moving to the hemodynamically significant PDA, then depending upon the clinical correlation of the baby, we'll decide whether to treat or not, sir.
So first important thing you saw is gestation age. We know that extreme preterm babies naturally will have prolonged ductal patency. It is not surprising. All preterm babies will have ductus. And more the preterm babies will have prolonged ductus. Second P is problematic. So what are the problems potentially correlated with ductus? What are the problems you see in that individual baby?
So with the significant duct, there is in extremely premature babies, there is increased incidence of IVH and pulmonary hemorrhage.
No. Pulmonary hemorrhage is very last stage. I'm talking about this hypothetical 26-week baby. Cardiologist comes, does the echo, and he shows say some millimeter or something he says. And there are two schools of thought. One is conservative, one is aggressive. Conservative people will say, don't worry, all preterm babies have ductus, let us wait. And aggressive people will say, no, this ductus can grow, it will create problem in the future, so let us treat. So there will be always two schools of thought. So have a midway between that. What are the factors we see? One is prematurity. In preterm baby, your tolerance for duration will be more. We know that extreme preterm baby will take long time. This is one factor. What is the second factor you consider before going for treatment or no treatment decision?
The respiratory status of the baby, like baby.
So one is oxygen requirement. Oxygen requirement is rising or falling. Another thing is, as previous speaker told about the pulse pressure, wide pulse pressure, tachycardia, which cannot be attributed to any other cause. This one, tachycardia, heart rate, precordial activity. Here now, this one another dilemma what we discussed in last speech is pulmonary hypertension. When pulmonary hypertension is present, is indication or contraindication for closure, because pulmonary hypertension can exist in two forms. P is equal to F into R. So sometimes F is high, sometimes R is high, sometimes both are high. So in the face of pulmonary hypertension, if you try to close, then baby can worsen. Or sometimes the ductus itself can be responsible for pulmonary hypertension. In this tricky situation, how do you decide whether to go for drugs or not?
If pulmonary hypertension is there and bidirectional shunt across PDA, we usually don't treat that PDA.
Because previous speaker also showed that very difficulty is there, because the excess flow itself can lead to remodeling. And this baby can go in for vicious cycle. Then baby can't be we can't close ductus because of ductus pulmonary hypertension is there. In that case, actually, we can follow one very easy clinical sign. When you see the precordial impulse, one is visible, second is palpable. Visible precordial impulse is different. Palpable precordial impulse, we can put two fingers. One finger near the sternum, one finger away from the sternum. Now, we get impulse. That particular finger is actually jumping with each heartbeat. Now, which impulse is more? Suppose right ventricular impulse, which is the finger near the sternum, is very prominent as compared to the away, that we know that right ventricular overload is more. And if away, there is left ventricular overload. This is very useful clinical sign. If left ventricular overload is there, usually it is volume. And right ventricular usually is pressure. So right ventricular pressure versus left ventricular volume. If right ventricular pressure is more, then it is more predominantly because of this one, this R factor. If left ventricular is pressured, it is because of F factor. Now, whole idea of ductal closure is to reduce F and hope that R will come down. So, careful palpation of precordial impulse, careful monitoring of pulse pressure can give you more important information along with echo, whether this individual baby falls into closure category or non-closure category. Because the complications of NSAIDs and complications of ductus, they are all same. Because ultimately, all NSAID has got potential for vasoconstriction. NSAID itself can lead to NEC. NSAID itself can lead to vasoconstriction. So there has to be risk-benefit assessment for each baby as well. So
Rahul, one second. Can I say thank you? I think today we're just little running out of time and we're already reaching 2 hours. Can I quickly summarize a little bit, because there is also an OSCE quickly to be presented. When I quickly asked them few this thing. So I think we had a long session today. I'll come back to you, Rahul. So if you just want to put something in a one-liner, we can get back to it. So one of the biggest thing I think for all the people as neonatologists would be with the PDA is when do you actually do an echocardiogram? And as you heard from Satyan, because I think one of the chat box, the message was, please give us a summarization about what to do a PDA. I think whatever I would say is just what probably we practice in our unit, or summarization of what is currently available evidence. And as you would have heard from Satyan, and if you hear from different experts, tomorrow you hear from Martin, you hear different, there will be a little bit of variation from different unit, but overall, so the basic message which we would like to do, summarization of what Dr. Satyan said, or Dr. Rahul is saying, or Dr. Ravi is saying, and beautiful presentation by both Dr. Puneet and Dr. Shravan is, number one is, so when do you do an echocardiography? So normally in a bigger babies, like more than 26 weeks, unless the child is symptomatic, you probably don't do a routine echocardiography. But if you are less than 26 weeks, there are some units, specifically, I think the Australian network, the Japanese, they do little early, maybe towards 48 hours. But most of the American units seems to be doing little later. I would say go clinically if you have obvious evidence of murmur or the thing. In our unit, we do at the end of 48 hours echocardiography of a child. And if the child have a hemodynamically significant murmur, then we would talk about treatment, which I'll come to that. And then we'll come back to Dr. Ravi, Dr. Manoj, and Rahul to see if they differ anything in what we spoke about. So that is about the timing of echocardiography. The second question comes is, what is hemodynamically significant murmur, or when do you consider PDA to be treated? So generally, most of us have gone off from aggressively treating PDA to being more conservatively managing them. So unless you score the PDA by either the echocardiography score, which could be as nicely presented, would be the size of the duct, or the flow velocity, the left atrial to aortic ratio, or presence or absence of the retrograde flow in the descending aorta, or of the size of the left ventricle. So there are different scoring systems which different units are using. But I think it is important for us to ask the cardiologist, or for all the neonatologists who are themselves doing functional echo, to make this assessment before we are deciding. And also clinical parameters like your respiratory parameters, what type of support is, because there's one of the questions in the chat box is, if the child is on CPAP, should I put should I start the PDA treatment? So how much effort is the child requiring? How much MAP is required? So if you are requiring effort is less than 40%, child's lung is improving, probably your approach is, and the duct size is small, your approach would be more conservative. But the same child, if the duct size is bigger, then maybe you'll be more aggressive. So it is a combination of your clinical parameter and respiratory parameter, which will determine which it is. One of the interesting things about treating, as Rahul has, so a lot of us have forgotten the clinical context, and we all have become very functional echo. Now, we all want to carry the probe. And I remember a lot of the questions which Dr. Rahul has been asking is, we were asked in our exams, all these questions were asked in our exam. What do you do PDA? And there were scoring systems about PDA, but how do you assess the child clinically? So it's very important to examine the child clinically also. So what is very important thing is, conservative fluid management initial days is very important, especially in the smaller preterm babies. Not because that and plus or minus diuretics based on has been used in units. And if you're using diuretics, maybe chlorothiazide is better than Lasix because Lasix probably cause ductal patency. This is what sort of has been there. There are some units which stuck to 120 to 130 ml per kg, unless your sodium is going up or you have some evidence of dehydration. This is some of the units which have been following up. Then coming up to the which one, because the question is raised about the TIP trial, talking about indomethacin, reduction of IVH, DETECT trial. So what do? Do we sort of actually talk about prophylaxis? If you look at the recent paper which looked about the risk of IVH and BPA in the era when TIP trial was done to the recent thing when conservative management has been done, the risk of IVH and BPD was significantly less when indomethacin was given in less than 26 weeks, and that is probably why Satyan and his unit has been using. So we probably need more research, and that probably answers some of the questions were put in the chat box about what is the future research. Is less than 26 weeks need to have the indomethacin, but mind you, I've seen in indomethacin causing a lot of spontaneous intestinal perforation and transient renal insufficiency, and we may need a little bit more data before recommending that, but that may be the only place where there could be research talking about that. But otherwise, most of the people would be talking based on only treating hemodynamically significant PDA. Many of the units in India have gone off to using paracetamol, and because IV paracetamol is available, the closure rates have been good, comparable to Brufen. Then now we have reviews, Cochrane reviews, meta-analysis on that, suggesting that very similar, and the incidence of side effects are less in that. The only thing, probably the smaller babies, whether the closure is similar, is the question mark raised. That is when the role of oral Brufen comes in our country, and we might consider using the oral Brufen in that. Indomethacin, and I would say in our unit, indomethacin, we haven't used indomethacin for a very long time. Though during my training period and overseas training, I've used indomethacin, but for some reason, there is a lot of fear factor with indomethacin. I mean, not be, it's a wonderful drug. It closes the duct. If you looked at some of the analysis which have compared indomethacin, Brufen, and paracetamol, always said indomethacin is probably little scores over edge between the other two, but the risk of side effects are more with indomethacin compared to this. So I think a lot of us still are comfortable with paracetamol. And then if you're not going, then we go for Brufen. And that is what our unit use. And then I'm happy to hear from the others, Ravi and Manoj and Rahul, of what they do. And there's a lot of evidence now talking about, whether you should use high dose Brufen. And of course, with paracetamol, we need to monitor for hepatitis toxicity and see from there. So this is what I think overall from PDA is what we have to see. The other question was about the sepsis and these things. And of course, sepsis, thrombocytopenia, hemorrhage, these are some of the problems which are very unique to our country, which we see a lot of IUGR babies we have. And that's when it becomes a relatively contraindication with some of the like Brufen. So that's one of the challenges which we face in our country. So this is, I think, I would say, summarize overall about the fluid management, when to do echocardiography, what should be your indication of using medication, and in what order we use in our unit, I can say. I can ask Ravi to sort of tell what he does in his unit briefly, and Manoj before, and Rahul can sort of, all can just put in briefly before we ask Vijay to present his ASCII.
Yeah, fine. I think the two fellows have presented quite nicely. They have shown the typical management and all the controversies. So I'd like to summarize now, as you have already told, those who are about 28 weeks, I think we need to do echo only when they're symptomatic. There is no point in doing an echo earlier and trying to find out whether they should be closed or not. If the baby is on significant respiratory support and we cannot wean the child off, then it is good to do an echo at that particular point. If either they may be in overt clinical signs or they may be indirect signs indicating that the baby cannot be weaned off the respiratory support. But for those who are below 26 to 28 weeks, here we need to be little more aggressive. Here we need to do echo on day 1 itself, those at least at between 12 to 24 hours of life, and see whether it is a kind of comprehensive evaluation has to be done, both the ductal characteristics and whether there are any signs of pulmonary hyperperfusion or systemic steal is there. So these kind of babies need to be treated. And in those NICUs where the incidence of IVH is quite high, I would prefer indomethacin in them. If the incidence of the IVH is low in these set of babies, then probably we can going for IV paracetamol or the ibuprofen. But if you see, the IV paracetamol efficacy below 26 weeks is not that great. So always prefer indomethacin or ibuprofen for those who are below 26 to 28 weeks. And those who are about 28 weeks, probably we can try safely with the IV paracetamol.
Manoj?
Yeah, actually, I mean, this PDA conundrum, I mean, it's so puzzling. I just reflecting like from the 90s, what we were told in 90s, then the first decade, and now, the things keep, we never used to, I mean, we never reach anywhere, it is keeping on with the evidence we evolved. Probably neonatology is all like this, shades of gray. But then as of now, what is the present, this thing we should all be knowing. So I really don't know what is going to be this. Every year there has to be a PDA symposium, and then we talk something slightly different from the previous year. This is what is actually happening. Very amazing, actually. Anyway, we had a very nice discussion today. So thanks to all the great legends like Professor Satyan and all that, and then plus the today's both the case the cases presented, both of them presented very nicely. So probably very nice session. Thank you.
Thank you, Manoj. Rahul, you want to say something?
Yeah. Actually, it has been summarized very well by Manoj. That it is puzzling, confusing, but every year we are growing. We are learning new things, and the carry-on message, as he is pointed out, is more of an individualized case-by-case basis, and based on clinical as well as hemodynamics. Thank you.
Thanks. Dr. Vijayanand, who's a consultant neonatologist at Rainbow Children's Hospital. I think all of you know him because he's regularly presenting now. Who comes up? Please, can you share your asking?
Sure.
Thank you.
So good evening.
Today has come a little late. Yeah, thank you. Thank you, Vijay.
Excellent discussion, as all the experts in India and also from US, we heard there is no consensus. So we yet to conclude on PDA in spite of so many studies. I'm not going to keep you long, and I hope you had a chance to look at the MCQs. You might feel a little bit tough, so I thought I'll go a bit easy on the ASCIIs. Okay. And first question, baby born at 26-week gestation with birth weight of 800 grams. On day 3, typical scenario, increasing ventilator requirements, a bedside echo was done. And have a look at the clip. I'll play it again. Yeah, already Punita showed nice images and nice clips. So the questions are, identify the view and key finding. Name 3 clinical parameters to identify the condition. She all very well discussed by Punita. And name 3 other echocardiographic parameters for the CBRE. I'll give you maybe 10 seconds to collect your thoughts. And Shravan also discussed very well. So congratulations to both those young speakers, emerging neonatologists. So I'm going to the answers. Okay, I don't know because I'm on the slideshow. I'm not seeing the answers. So you may be, so parasternal short axis view, large PDA, and 3 clinical parameters. I mean, already Rahul's are nicely discussed, and the clinical, whatever the investigation you do, clinic, that is not a substitute for your clinical examination. These all should be, clinical examination should be done. And then other echocardiographic parameters for the severity, I'm not going to read. If you have written any of those three, I will answer them. But remember, whenever we say this baby has a PDA, my trainee would immediately say there is no murmur. Remember that murmur is not the sole feature. In fact, as Punita nicely discussed, that a large PDA may not have murmur because there won't be too much of pressure gradient. And other cardiac parameter, again, she discussed very beautifully. And here I would summarize saying that a PDA per se, is it how big? What is the flow? Is it large? Again, remember what Satyan sir said and also Rahul sir said. And with comparison to the weight, there are scoring systems. And also, what is the flow like? Is it a restrictive flow or is it a pulsatile flow? And then that is about PDA. And then two important other characteristics we need to find out is the pulmonary overcirculation. That means left side is dilated or not. The most commonly used parameter is LA to aortic ratio. Somebody is also asked what is E to A ratio. E to A ratio is a left atrium to the left ventricular inflow ratios. These are two waves which come E and A, and there's a severity scoring based on that. And also another one used is the left ventricular output. And the systemic hypoperfusion, again, she showed nice diagrams like your flow to the aorta, descending aorta, and celiac artery and MCA. And putting all two together, you will decide whether it is hemodynamically significant or not. These pictures are already showed by Pranita. I'm not going to discuss them. So next question for you guys. And a 7-day-old baby born at 27 week, and you are very good, thorough with your clinical examination and came to your consultant that there are features significant PDA. And this baby is already ventilated, and this is the X-ray you can see. I'm going to play this video for you, and this is a bedside echo. Okay? Okay, one more time. Oh. Okay, questions are mentioned 2 key findings on chest X-ray, which again is been discussed by the previous speakers. Identify the echocardiographic view and key findings. What are the potential life-threatening non-cardiac complications this baby may develop? 10 seconds. Okay. So as you can see, I think I didn't stop for 10 seconds. Okay, here are your answers. The pulmonary edema, pulmonary overcirculation, pulmonary congestion, and cardiomegaly. And typically you have a lot of left atrial enlargement. And also sometimes you can see the ductal bump also. Here you don't see that much. And a cardiomegaly. And of course, 4-chamber view, that's the view. You can say either it is subcostal or I don't know whether apical. And you can clearly say a dilated left atrium and left ventricle. And usually in unit, right is the dominant, but here is a very dilated. And the 3 life-threatening complications which we enumerated here are pulmonary hemorrhage, IVH, and neck. I'm going to stop it there, sir.
Yeah. Thank you again, Vijay. I know, thank you for all the hard work. I know making OSCEs and doing MCQs, you need a lot of efforts. I hope all the students are taking benefit of the thing and answering all the MCQs. It has been posted in your group. And first, let me congratulate both Dr. Puneet and Dr. Shravan for the excellent presentation. It was a good summary about PD. They have done a great job. And I'm sure this is possible because of Dr. Ravi Shalkar's excellent sort of supervision. I think we personally supervised their presentation. Thank you, Dr. Ravi, for personally taking care of them. And I'm sure most of the students would have benefited from that. And I know Dr. Satyan and Frank have left, and I know it was Frank's lecture has been an eye-opener. I hope we will have more of this interventional cardiologist available. I'm not sure what will be the cost of this, but it looks very sort of interesting, challenging. That yes, if you could do a device closure in the small babies, we probably don't have to worry about too much. Because I'm sure a lot of us, we have gone to 2 courses of the drugs, the child's duct is still there, we're really not sure whether we subject the child to surgery, we hold on for 2 weeks, this child develops bronchopulmonary dysplasia, start developing spells. So we go through a lot. And if something this can be done easily, I think it will make the neonatologist's life a lot more easier. I hope the expertise starts developing in our country, and affordability would be this. I don't know how much it costs. And that is one thing which we probably look forward to. But one thing we have learned today is that it is feasible, which will probably send a good message. That's the reason why we included that lecture, to send a message that it is possible to do that in small babies. I take this thing for thanking Dr. Rahul Yadav for sort of being an expert for this session, and for his input to the students, and giving all the clinical sort of questions and advices to the students, which a lot of time we forget, because I think it's a bedside. How do we assess that? To summarize, I know all of us, I know we don't have a right answers to PDA, and I'm sure even after the end of all this presentation, we all will have still confused what to do. Someone has asked this, tell us what to do. Should I use indomethacin? Should I use Brufen? Should I use paracetamol? I don't think we had the right answer, because efficacy-wise, similar almost. Prophylaxis, I think many of us have gone away from prophylaxis. If there is an area of research, people are looking at prophylaxis only the less than 26 weeker, and that is what I would say. So I would probably go against saying that give prophylaxis. But if they are talking about prophylaxis, they are talking about less than 26 weeker, and they're talking of indomethacin. And there shouldn't be any IVI, there shouldn't be any renal injury, there shouldn't be any thrombocytopenia. These are the contraindications, or necrotizing enterocolitis. And if you're talking about which drug, I think at this stage, a lot of us are, flip-flop between the Brufen and paracetamol. It's your choice. Both are equally efficacious, and the risk of side effects a little less with paracetamol. Yes, we do not have any long-term trials with paracetamol, and especially with the small babies, I think we are seeing sometimes the duct reopening and other things are there. We probably have more data coming up in future to answer these questions. So thank you all once again for sort of joining today. And I thank Dr. Manoj for again sort of helping us to host the session. Thank you, Manoj. And thank you, Dr. Vijayanand, for the.
You are doing a wonderful job. Everybody will say that. You are the, Dinesh Chirla's golden touch is taking NOEL to newer heights.
No, it's nice of you. And thank you, Ravi. Thank you so much, Ravi. Thank you. And just to say, we had just preponed the Dr. Satyan's session. So next week, we are going to have the session on functional echocardiography and point of care ultrasound. So next Thursday, please join back. We'll send more information and the links. So please join for the session on functional echocardiography and point of care ultrasound. Till then, please answer your MCQs. And thank you. And well done, Dr. Puneet and Dr. Shravan. Thank you.
Thank you, sir. Thank you.
Thank you, sir.